weekly DMA IMA NDB Meet. This is our 76th consecutive meeting, and we are happy to announce that we would be starting a series on inflammation from today. We do have our speaker, Dr. Nidhi Dhawan, who is the Associate Medical Director of ENT and the Head of the Safety Committee and Shock Charity Hospital in Daryaganj. She has been taking all the sessions for this particular meeting for us and enlightening us, and as she says, educating herself as well. So, without much delay, I would hand it over to Dr. Nidhi to launch this session on inflammation and the series on inflammation. Over to you, Dr. Nidhi.
Thank you so much, Dr. Meenakshi. I think what the COVID epidemic has taught us is that going back to the basics and approaching it from there really tells us that we are not really repurposing the drugs, we are only repurposing the indications, because the drugs have the same pharmacology and the same mechanism of action, and it's targeting specific parts along the inflammatory pathway. So we will pick up a particular part of inflammation today, which is relevant to the present times, and we will carry on from there. As usual, we'll start with the COVID update. So, in the last 2 weeks, we have heard a lot about Europe and particularly UK having another spike and reaching almost 100,000 cases a day. Given UK's population, this is significant. And given the fact that they think this could be driven by Delta plus AY.4.2 is again significant. But I think if we go a little deeper into the picture, this is largely driven by public behavior and largely driven by Delta. If Delta plus was that virulent and concerning, it would have overtaken UK's cases by now. And UK has been doing genomic testing as a routine. So this is about 6% right now for UK. So even though we have to remain watchful, and now is the time for India also to manage public behaviors, we have to be watchful but not apprehensive that Delta plus might be the next big thing happening. So we started October with about 25,000 cases a day in India and a 7-day rolling average of about 24,000. As of 28th of October, we had the week ending 28th of October, we had 14,348 cases and rolling average of 14,700. So if you are seeing the daily new cases is also less than the rolling average for that week. On 27th October, this was the reverse. The 7-day average was 14,000, whereas the new cases were 16,000. This was more. 26th October, the new cases were 13,450 and the 7-day average was 15,000. So if you have a stable metric where the new cases is less than the 7-day rolling average, you are going towards reducing caseloads. Of note is that from 25,000, we have finished the month at say 15,000. And this has been a progressive fall. This is for India in general. There are a few regions of concern. There are vaccination needs to be upped. We may have to rethink intervals between the 2 doses. We should try to have as many as possible vaccinated by the end of this year. Right now, we are poised where we were in March, where we thought that everything is over, with one difference, that about 60% of our population is vaccinated. So if we look at Delhi, it is showing a significant downtrend, both in the confirmed and in the active. If we look at Maharashtra, it is showing somewhat of a plateau on confirmed, but it is showing an upward trend in the active. If we look at Uttar Pradesh, significant downtrend in both. And if you look at this, Delhi is about 334 active cases, Maharashtra 18,500 active cases, Uttar Pradesh 98. Now, if you compare this with US, Uttar Pradesh population is comparable with the population of United States. United States, it's hitting 100,000 cases a day, active cases being more. So given this difference, ivermectin might be working. So Kerala, 78,000 active cases, beginning to show a downtrend in activity. Number of cases is too high for comfort. The 2 states out of this that have aggressively used ivermectin have been Delhi and Uttar Pradesh. Despite all the controversies, ivermectin targets the nuclear factor kappa beta pathway, which targets the IL6 pathway, and I think that is a significant advantage we have. As of 30th of October, this is 8 a.m. The Government of India update across India. We have about 161,500 active cases, with an daily caseload of 14,000 and daily deaths still around the region of 500. Vaccination status is looking encouraging, with 63 lakh vaccinations given the previous day. The vaccinations now might begin to taper off, because if maximum number of people have already received their first dose, now the second dose is scheduled only after 3 months, which is something that we might now rethink of, so that we increase the second dose coverage also. So good vaccine coverage. As I was telling you about the difference between the alpha and delta, if we look at this, the the mean intrinsic virus generation time for alpha is about 5 to 7 days, and for delta it is about 3 to 5 days. If you look at overall transmissibility, there is a significant, the B part of the picture, there is a significant difference between alpha and delta. The overall transmissibility quotient for alpha is 2, whereas for delta it is 6. The mean generation time and transmissibility resulting in household transfers, the alpha tends to infect the whole household within 2 days, even before you have realized the delta, even before you have realized that you're sick. Whereas the alpha will take around 4 to 5 days to do the same. Now, it is proposed perhaps that the delta plus is 10% more transmissible than Delta. It is currently probably about 6% of UK caseload, and it has been prevalent for about a month. That is not consistent with a severely dangerous variant. It appears that it is not going to be completely displacing Delta. However, it is a variant of concern and a variant of interest. We must continue to watch how it moves in the coming 15 days. This is a violent chart of alpha and delta in unvaccinated, first dose vaccinated, different age groups, and how they there is the mean generation time, the household depletion of susceptibles time. So these are largely comparable. These are not significantly different. The government of UK has released this on the official website of COVID-19 trackers, where they say that the whole genome sequences resulted in a data of about 6% being Delta plus. Now, as I was telling you, had it been like the difference between alpha and delta, Delta plus would have overtaken Delta by now. So the evidence is still emerging. So far, it does not appear that this variant is causing more severe disease or is rapidly more transmissible, but the continued study is needed. Interestingly, the Zoe app, the symptom tracker app, is showing that the symptoms are definitely changing. Now, fever and cough are not the primary symptoms of COVID. Now it is headaches and body pain, which are the primary symptoms of COVID. And given that we are in the midst of a possible dengue epidemic, headache and body ache become significant for us to differentiate the two. So CBC, serial CBCs with CRP, to watch for platelet and to watch for lymphocytes will remain the main focus of interest for us. The world picture, and again, since we are going to be starting inflammation, I would like you to see this very carefully. The top 5 countries: USA, India, Brazil, UK, and Russia, and Turkey to some extent, all have significant problems with obesity. Brazil has young onset obesity, so the age group between 20 to 50 is significantly obese in Brazil. USA is supposed to be the obesity capital of the world. Nearly 70% of the population is overweight or obese. India, much as I thought India was in a very bad situation, if I look at WHO figures and the statistics that Statista releases, our World in Data releases, it didn't quite fit, and I was surprised at what was showing up. But we in India are considering obesity as an emerging epidemic. So the new cases globally are kind of flattening out, but not really going down even now. This seems to be driven by Europe now. Earlier it was driven by US. Daily deaths, again, doesn't seem to be coming down, driven by Europe. If you look at the world figures are going up. US seems to be flattening. Ethiopia well, not even there. UK seems to be flattening. India going down. Ireland is showing a slight uptick. Zambia and Ethiopia I have included here for the African representation. These are the part of the sub-Sahara Africa which does not have obesity, which has HIV, which has not had vaccination, and which is in the belt for ivermectin coverage for river blindness. We have seen the least number of variants emerge from Africa. We are seeing the least number of cases emerging from Africa. And we are seeing that the mortality is not so bad in Africa. So daily new confirmed cases for the week ending 29th of October, in India, it was 8.8 per million, and US was 215 per million. UK, 609 per million. And if you look at Nigeria, that's somewhere here, this part. Nigeria, 1.12 per million. Russia is in the midst of a bad wave. US is only now beginning to show some downtrend. Australia, which had remained isolated for so long, is now beginning to show some cases. Indonesia, Thailand, Japan, some cases. UK, if you look at UK, UK is the darkest. If you look at Europe, again, Europe is driving the present caseload. Looking at biweekly change, China is back, plus 90%. US in the last fortnight has shown a downtrend, minus 20%. India, minus 21%. Russia, plus 30%. We don't yet know what is driving China. Not much literature available there. Daily new confirmed deaths. You look at this, Zambia, poorest country of the world. Where is it? Practically not there, 0.29. US, this is the 7-day average. So US is pretty high. Now it is beginning to uncouple from the number of cases. India has done pretty well, but not yet quite flattened. UK, not in a good position. So if we look at this, US is about 1,500, India is about 600, UK 150, Ethiopia 14, Zambia 0.2, Israel 6. Israel does not have obesity. Israel has had good vaccine coverage. US has obesity. US has had good vaccine coverage. The two are very different profiles right now. With obesity and inflammation being about 70% prevalent in US and Israel being the fitness capital of the world, you see the difference in mortality. So if we see the number of deaths, the number of confirmed per million, India is at 0.4, US is at 4, and Nigeria is at 0.03. Cumulative deaths the week ending October 29th, India 328, US 2,238, Brazil 2,838. Difference being, again, obesity. And if we look at vaccines administered, Africa is practically transparent. The Chinese coverage has been maximum, Canada, US, South Africa, South America, Europe. The parts of the world where vaccine coverage has been the greatest are the parts of the world right now showing an increase in number of cases. These are also the parts of the world which are more obese. So share of the people who have received at least one dose of the vaccine, Ireland is way up there. It's the top. UK, about 70%. Ireland is hitting 90%. Israel, 70%. US, about 65%. India, we are still less than 60%. The world itself has got about 50%, and of which only 3% vaccination has been delivered to the underprivileged or the third world countries. Ethiopia and Zambia are way down here. And these are the ones which are showing least number of cases and least number of deaths and least number of variants emerging. That seems to be because there is least obesity here. And it's not as if we are testing less. So we are testing according to our caseloads. US is doing universal testing. UK is doing universal testing. For each confirmed case, UK needs to test about 33 people to get one confirmed case. Israel 22, Ireland 18, India 17, US 13, Ethiopia 10. If you look at the obesity map of the world, it is the same as the COVID map of the world. The obese countries are right now in the midst of the pandemic. If you look at deaths from obesity, India is quite high. US is the highest. Italy, UK, France, and look at Japan. Japan is, again, very lean people. Share of children who are overweight, it's again the same. Russia, US, Brazil. We are beginning to make this correlation between chronic inflammation of whatever cause. Obesity is a significant thing that stares us in the face, and susceptibility to vulnerability to COVID and its complications. So making that case, let's come to inflammation and see. We are not going to go into very much detail about the basics of inflammation. We all know the 5 signs of inflammation. We all know how that happens. And so inflammation basically is of 2 types, acute and chronic. Significant difference between acute and chronic being that in acute, there is leukocytosis of the polymorphonuclear cells variety, whereas in the chronic, it is more driven by lymphocytes and macrophages. The acute inflammation largely is limited to the extracellular compartment, whereas the chronic inflammation tends to attack the connective tissue and the blood vessels and causes some proliferative and fibrotic changes. If we look at the metabolic syndrome, the metabolic syndrome is marked by obesity, inflammatory adipokines, leptin, IL6, TNF-alpha, monocyte chemoattractant protein 1, and resistin. Now, IL6, TNF-alpha, and MCP1 are drivers of intense chronic inflammation. They're also markers of acute inflammation. So they seem to be the connection between the acute and chronic inflammations. The pro-inflammatory, anti-inflammatory balance is between IL6 and CRP and adiponectin, which seems to be protective. Adiponectin is the balancing chemical for the inflammation that is due to obesity. So this is going to be the paper that we're going to largely study. And it links at a molecular level what could be happening with obesity. And that is quite instructive on what could be driving the pandemic in these obese nations. The IL6 seems to be the molecular connector between acute phase inflammation and chronicity. As we know that there are two basic types of fat available in the body, the white fat and the brown fat. The white adipose tissue is largely truncal, whereas the brown adipose tissue is largely found in the shoulder area. The white adipose tissue has some role in immunity and inflammation, and a third of the IL6 circulating in the body, 30%, comes from adipose tissue. In obese individuals, there is both a hyperplasia and hypertrophy of adipocytes, which means that not only are there more number of adipocytes, but also these adipocytes are bigger in size, which results in insufficient blood supply or hypoxia. The hypoxia of adipocytes triggers the cascade of necrosis, and necrosis causes macrophage activation. So the connection between the acute phase IL6 and the chronicity of activated macrophages and inappropriate macrophage activation is central to the chronic inflammation of obesity. IL6 also strongly stimulates the hepatocytes to produce CRP, which is an acute phase reactant. And the IL6 CRP cascade results in the effects of the metabolic syndrome and chronic inflammation. The free fatty acids accumulation further triggers the serine kinases and CRP upregulation. So CRP tends to stay elevated. There were several studies to bring about the correlation between BMI and IL6. So if the BMI is less than 30, the IL6 stays less than 1.5. If the BMI is between 30 and 35, the IL6 rises to 1.6. And for BMI more than 35, the IL6 rises to 2.2. This is predictable, it is consistent, and it is almost a marker of obesity. The plasma mean plasma IL6 in portal vein is 50% higher in obese subjects and parallels the CRP. So obesity in itself causes a pro-inflammatory state due to increase in IL-6 and increase in TNF-alpha and a decrease in adiponectin. The macrophages that are inappropriately stimulated cause an activation of the Janus kinase pathways and the toll-like receptors, and IL-6 working through the NLRP pathway causes activation of the nuclear factor kappa beta. This increases the free radical oxygen species and decreases the nitric oxide, which causes endothelial and microvascular damage. The alteration in the glucose and lipid metabolism, the pro-inflammatory state, atherosclerosis, insulin resistance, hypertension, all are subject to mainly IL-6, but aided by parallel rise of TNF-alpha and fall in adiponectin. So IL-6 at a molecular level promotes the cluster of differentiation of CD4 cells. It promotes T helper cell differentiation towards Th2 and Th17 both. So it causes both a heightened allergic response and a delayed cell-mediated response. It blocks T regulator cell differentiation, causes neutrophilia. So it is a marker of acute phase. It has some B cell stimulatory effect. So it is also, there is a nuanced dance between immunity and inflammation in the long term. It has two pathways of activation, the trans and the cis pathway. If you see the bottom here with the yellow IL-6 molecule, the trans pathway is through the transmembrane IL-6 receptors, which causes increase in the blood vessel damage through VEGF, MCP1, and decreased calibrin. The cis signaling signals lymphocytes to increase Th17, CD8, and plasma cells, but it decreases T regulator cells. The nuclear factor kappa beta is the key transcriptor for both IL-6 and TNF-alpha. And if you see, the IL-6 is produced by most cells in the inflammatory pathway. It is produced by neutrophils, macrophages, T cells, B cells, monocytes, endothelial cells, epithelial cells, and dendritic cells. The role of dysregulated IL-6 has been shown to be significant for autoimmunity, for acute phase bacterial infection immunity, as well as for prolonged metabolic derangements. As I said, the nuclear factor kappa beta is the central molecule which drives both IL-6 and TNF-alpha. Both are raised in obesity, both are raised in COVID, both cause chronic cell-mediated damage of autoimmunity, as well as chronic inflammation and metabolic syndrome. This is something that we have seen in the past, and we have seen how the survivability drops in stage 3, where inflammation and thrombogenicity set in. But what I want you to see here is the third graph. This is IL-6. In non-survivors, IL-6 is significantly raised by day 20, third week. So what is the role of IL-6 in the metabolic syndrome? IL-6 is the balancer between M1 and M2 macrophages. M1 macrophages are are activated in the presence of fatty acids and lipopolysaccharides. M2 macrophages, IL-6 works on them in the presence of IL-4 and IL-13 to increase the formation of M2 macrophages, which cause insulin resistance and gluconeogenesis. M1 macrophages cause lipolysis and insulin resistance. So this balance is disturbed in presence of IL-6. IL-6 is actually blocking M1 and promoting M2, leading to chronicity. So IL-6 deleted mice are more insulin resistant, with high fat diet and more glucose intolerant with routine diets. IL-6 is found to be elevated in chronic nutrient access to tuning macrophage activation towards pro-inflammatory pathway. Is this a meta-inflammation? There is an M1 predominance which increases the level of saturated fatty acids and adipocyte-derived cytokines and causes an increase in insulin resistance. There are present papers in the US which are talking about obesity and insulin resistance, but this might be the connecting link between the two. IL-6 is actually the balance between catabolic and anabolic pathways of the body. It is catabolic because it causes lipolysis, and it is anabolic because it increases insulin sensitivity through M1. The lowered muscle mass and grip strength seen in obese individuals seem to be mediated by IL-6. So the classically activated M1 macrophages, along with TNF alpha, IL-1 beta, IL-6, and resistin, are pro-inflammatory on adipocytes and cause increase in obesity. Alternatively activated macrophages in the presence of IL-10 work on adipocytes, but in the presence of anti-inflammatory adiponectin, increase insulin sensitivity and cause lean and insulin sensitive individuals, which means that the dance between adiponectin and IL-6 is what is going to determine how sensitive we are to insulin. The size of adipocytes and the number of adipocytes that express insulin receptors and work with insulin is what creates the sensitivity. Coming to the next marker, CRP. So CRP is an acute phase reactant, but it is also the marker of systemic chronic inflammation. There has been some workshops which have come to the conclusion that it is a simple, cheap, quick, standardized test, but most importantly, it quickly responds to intervention. And sir used to say that 48 hours mein chadega, 24 hours mein fall karega. So it quickly responds to intervention. Of note is that it may be raised in hormone therapy, pregnancy, while a person is on birth control pills, and in some chronic inflammatory conditions like arthritis or irritable bowel disease. It can be lowered by treatment with statins. It can also be lowered by some anti-inflammatory drugs and steroids. Each standard deviation rise of CRP is associated with a 60% rise in the risk of cardiovascular disease. Each degree of obesity is directly related to rising CRP. So the slogan CRP less than 1 is something that we need to rethink of. The waist to hip ratio correlates very, very faithfully to CRP. It is a sensitive index of visceral obesity. Why is CRP and liver so important for us to monitor? So liver is the central organ for inflammation. It is the site of drainage of free fatty acids and TGAs, and it triggers the IL6 from adipocytes, which triggers the hepatocytes to upregulate CRP. So actually, liver health is also indicated by rising CRP. How are IL6 and CRP actually correlated with each other? IL6 and IL1 both stimulate CRP, and not only they stimulate the synthesis of CRP, but also the secretion of CRP from hepatocytes. Now, the farnesoid X receptor, or Fxr, inhibits induction of IL6. What is Fxr? Fxr is a ligand-activated transcription factor, which is a member of the nuclear receptor subfamily, which is the pathway for nuclear factor kappa beta. This is also the part where ivermectin is working. This is highly expressed in the liver, intestine, kidney, and adrenals. Liver, intestine, and kidney are also very highly susceptible to COVID-19. Also very highly involved with obesity, diabetes, all the chronic inflammatory and metabolic diseases. Fxr regulates genes for bile acid and lipid metabolism and induces enos and vascular epithelium. So Fxr is the protection of smooth muscle. It inhibits smooth muscle inflammation via nitric oxide and cyclooxygenase pathways intrinsically. This inhibits hepatic CRP. So there is a dance of pro and anti-inflammation which is going on in the liver, and diet, exercise, and the chemistry are dancing a fine dance. The call to action is that we have to rethink about CRP less than 1, promote it in general population, and start talking about CRP as and waist to hip ratio as the new gold standard of testing. So recent advances in obesity-induced inflammation and insulin resistance show that more obese individuals have more adipocytes but less insulin sensitivity, because the receptors are both downregulated as well as do not work as efficiently. C-reactive protein is that dotted line, if you see. This rises quickly and falls quickly, but it will stay high in patients with chronic inflammation. I think I'm going to ask Meenakshi to talk about that one, but a very interesting indicator that might be emerging now is the Fxr, fibrinogen albumin ratio. Albumin is decreased in acute inflammation, but it is anti-inflammatory, and fibrinogen is increased in inflammation and is pro-inflammatory. So the fibrinogen albumin ratio might be another simple test to do, which indicates whether a patient is resolving or moving into chronic inflammation. So what can you do about obesity and inflammation? Excess nutrient is, of course, one of the reasons why obesity has become such a pandemic, but also sitting is the new epidemic, lack of activity is the new epidemic, and with the present lockdowns and reduced public mobility, it has further heightened the decrease in activity and increase in snacking, and people mindlessly falling into the spiral of obesity or overweight at least. So that 6-minute walk before breakfast and after dinner will give you at least 20 minutes of exercise a day, 12 minutes. If you can do just 4 minutes of the nitric oxide sequence that we discussed in the last week, we've got 12 plus 4, 16 minutes of exercise in a day. And even 15 minutes of exercise significantly improves health outlook in people who have been inactive. This is again talking about the role of adipocytes and the dendritic cells and macrophages. So macrophages are pro-inflammatory M1. This dominates over M2 in obesity and causes both TNF alpha and IL-1 beta associated damage. Adipocytes are the predominant cells in adipose tissue, and they release adipokines including IL-6 and adiponectin. Adiponectin is less, hence the chronic inflammation is more. IL-6 is more. It's the balance between IL-6 and adiponectin which will cause the balance to be tilted one way or another. So IL-6 through the nuclear factor kappa beta MAP kinase pathway, the phospholipase 3 pathway and the STAT pathway causes all the effects of immune and metabolic imbalance. I will not go into the IL-11 pathway right now, but epithelial survival, autoimmune diseases, extracellular matrix remodeling and fibrosis, cancer, autoimmunity, everything is here. We've discussed this already, that in the lean state, the resident macrophages are M2, which work through IL-10, whereas in the obese state, the main macrophages are M1, which decreases the adiponectin and causes insulin resistance in liver as well as muscle. These are again some of the pathways that IL-6 works with, and the possible so tocilizumab, sarlimumab, these are IL-6 inhibitors, baricitinib, JAK-STAT inhibitor. These will cause decrease in IL-6, circulating IL-6, and at least mitigate the acute phase reactant effect. But for the chronic effect, we need to work on diet, lifestyle changes, and the metabolic syndrome. The acute inflammatory response tends to move into the chronic inflammation with organ fibrosis and delayed wound healing. That is because lipoxins and resolvins are suppressed in chronic inflammation, and resolvins are particularly important for wound healing. But if it normally proceeds from acute inflammation to a resolved state, there is homeostasis and there is adaptive immunity. Omega-3 polyunsaturated fatty acids promote homeostasis. So IL-6 signal can be blocked, and that would result in decreased Th1 and Th17 response. It would result in decreased nuclear factor kappa beta activation and decreased chronic inflammatory state. So it has been found that spike protein is also pro-inflammatory. In obese individuals, the COVID severity is at least 6 times more, and chances of vaccine-induced side effects is also about 6 times more. That is not to say that these people should not be vaccinated. That is to say that these people should actually be counseled to take care of their body and to take care of the metabolic syndrome. So therapeutic approaches to inflammation have so far been suppressing the final outcomes, or blocking the known pathways, or inhibiting some of the pathways. The pro-inflammatory mediators of inflammation in willow bark, aspirin, crocin, these are the ones which we have been using largely for inflammation in the past. But right now, the field is open, and there are a lot of things which we can now use to suppress chronic inflammatory pathways, including and not limited to ivermectin. If we look at India's obesity scene, 73% of urban Indians are overweight. Now, this is what I'm getting from Indian sites and Government of India releases. This is not what I'm getting from our World in Data, and I'm not saying that we shouldn't look at it, but I'm saying that the picture needs to be clearer, and we need to be more present on the global scene to figure out that, you know, what people access as data must be authentic. So the maximum risk age for obesity is between 28 to 38 years. That may be related to the increased work pressure and in long working hours, being limited to a desk and not looking after your physical health. The highest risk of weight gain for both men and women is in this age group, but it is more for women than for men. At an average, an Indian needs to lose 11 kgs to fall back into the normal metabolic state, and 11 kgs, believe me, is not easy to lose. The biggest burden of obesity on healthcare, if we look at the list, according to Statista, India is way down here, 6%. And USA is way up here, 14%. Now, if you look at the countries here, USA, Italy, Spain, Brazil, Russia, UK, Australia, Spain, these are the countries which are having the present waves, which is driving the pandemic in the world. Share of obese adults, as I said earlier, is the same map as the present COVID map. US, Europe, Russia, Brazil. So COVID's obesity connection, we are seeing that countries which are less obese have fewer than 10 COVID deaths per 100,000. Countries which are more obese have over 100 deaths per 100,000. The difference is less than 10 and more than 100 per lakh population. It's not a small difference, it's a very significant difference. So this is just a brief overview of which drugs will suppress the IL-6 pathway, and we can go into that some other time. But this is something that is very, very concerning. Obesity increases the morbidity 100-fold, 1,000-fold maybe, less than 10 and more than 100. I think I'll stop here, and Kiranji has a question.
Yes, the figure they have taken now, like 80% of our people have got antibodies. How they have taken out this figure?
There was an ICMR survey. In fact, there have been series of ICMR surveys which focused on different populations. It focused on children, 12 to 17 years old. It focused on the office goers, and it focused on the elderly. The figures did not say universally we have 80%. They did say that there are some states where, so in Maharashtra, even the children population is around 67% seropositive. In some states, this is less. I think it is less in it's less in Kerala. I'm not sure.
No, all I want to know is that, like, if they test 2 lakh people, they can take out the figure 80%. They don't have to test all of them.
Ma'am, there is a statistical projection and a statistical correlation. So in statistics, depending on sampling, and you can say that there are sampling errors, and so the study is not valid. But when ICMR does a study like this, they do random sampling, and they make sure that it is representative. If it is random and representative, then they can make statistical projections to the whole population.
Okay.
This is a statistical method of doing things.
Okay, thank you. Layman is raising these questions actually.
नहीं मैम, वो ठीक है, question मतलब question ठीक है, but the fact is that statistics is a very involved science, और हम सब लोग जब research करने लगते हैं तो statistics is the first thing that we should be doing. We should actually not be talking about scientific questions. We should be talking about scientific statistical significance. So that we go from there, from the basics, we can project. अगर मैं सिर्फ 10 लोगों को सैंपल करूं तो मैं पूरी सिटी को नहीं प्रोजेक्ट कर सकती, लेकिन अगर मैं 2 लाख को करूं तो मैं कर सकती हूँ. So there are some tests like chi-square test, student T test. They have a number which correlates to statistical projection. So अगर आपको कोई clinical study करनी है तो आपको minimum sample जो चाहिए होता है वो 30 चाहिए होता है. Now you can from that sample say that for a population that can be represented by this,
okay,
we can make a projection of this prevalence. And 30 is a very small number. That is why जब हम लोग अपने thesis लिखते हैं तो हम 30 cases से 50 cases पर शुरू करते हैं.
ठीक है, thank you. Another is that giant cell arteritis.
हाँ जी.
What is that giant cell arteritis? You know, it has been compared with COVID. Giant cell arteritis causes blindness.
Ma'am, giant cell arteritis is where the chronic cell-mediated immunity causes damage in the endothelium, and there are macrophages in the vicinity. So parallels are there. And I think this might be TNF alpha mediated. I'm not sure. But as I was telling you, जो end arteritic ulcers दिखते हैं diabetes में, which which cause extending areas of necrosis. I was seeing similar skin manifestations, and I have come to know that there are other people who have seen it also. I will put a picture of my father's legs. He's responded beautifully to TNF alpha antagonism. He's responded to Trental, and he was not responding to anything else. Usually we say that Trental ka action, pentoxifylline ka action is slow to onset, and it takes about a month before you decide that it's not working. He has responded in week to 10 days.
Okay.
Now, why I'm saying this is because मैंने आपको पहले भी बताया था, उनको मैंने सबको दिखा लिया. I've shown him to physicians, I've shown him to pathologists, I've shown him to radiologists, I've shown him to endocrinologists, dermatologists, surgeon, and everybody has just come back blank to me and said कि हमें नहीं पता क्या हो रहा है. So after, and that's why I'm really grateful to this group, which makes me study, which makes me explore, and I was trying to figure out what could be causing these end arteritic ulcers, and TNF alpha comes out as the main culprit. And next time we'll do TNF alpha. Today we've done IL6 and its relates. Next time we'll do TNF alpha. So pentoxifylline is a rheologic agent. It improves circulation of blood, which means that it increases the flow of blood to otherwise blocked areas. It is not a blood thinner. It is not an anti-clotting agent. It simply improves circulation. So it has no side effects that you need to be watchful for. Its effect begins in about 2 weeks to 4 weeks. So don't stop before that. Keep monitoring the patient. But these end arteritic or giant arteritic changes might respond to TNF alpha antagonism.
So should we continue it for certain cases? Should we continue it for lifelong?
Ma'am, actually,
like scleroderma?
I haven't gone into that much detail, to be honest. But मेरा ये मानना है कि we must follow the chemistry and see how the resolution is taking place. हम लोग ना एक दवाई ऐड ही करते जाएंगे, नहीं तो somewhere there has to be an end point, except for diseases which have no end point.
Madam, in mucormycosis, which cells are responsible?
In mucormycosis?
Yes. Which cells are
cells are responsible?
Yes.
Cells matlab? Mucormycosis is an no. So mucormycosis is an angio-invasive fungus which अगर हमारी इम्यूनिटी अच्छी है तो हमारी बॉडी म्यूकरमाइकोसिस को इन्वेड नहीं करने देती. So long as it remains a surface infection, it does not cause any problem, whatever the cell. Now, if it invades a blood vessel, it causes damage to the endothelium. If it invades the nasal mucosa, it causes damage to the mucosal surface. If it invades the lung parenchyma, it causes a damage to the pneumocytes, and it is promoted by thrombosis. It is promoted by ischemia. So it is not a particular cell that we are talking about here.
Okay.
It has got skip lesions. Mucormycosis has got skip lesions. So it may be that it is not present in the nose and it is present in the cavernous sinus.
Why this giant cell arteritis is called giant cell? some
मैम वो
giant
उसकी histology है मैम.
अच्छा, ठीक है, thank you.
May I ask you one question, please?
Yes sir, yes sir.
Ivermectin is supposed to prevent COVID. So what is
Ji,
the
sir.
latest view and what is the preventive dose of ivermectin according to the latest literature or latest view? Ivermectin.
So there are many controversies on ivermectin. The people who want to not take ivermectin will say it is bunkum and nonsense. My view is that there is enough public health evidence now to use ivermectin, both in terms of safety. It has been in use in Africa for river blindness for last 40 years. And in terms of efficacy, Mexico, Goa, Uttar Pradesh and Delhi have shown it. The present recommended dose is in terms of, I think, body weight, it is 0.2 to 0.4. Meenakshi, can you correct me?
Come again. The ivermectin dose.
Ivermectin dose in terms of body weight. It comes as a 0.2 to 0.4, hai na?
Just 1 second.
0.2 to 0.4. If I might be mistaken.
Yeah, I think it's 2.4. I'll just check and I'll tell you. Hold on.
Yeah, so per kg body weight, it comes in two strengths, 6 mg and 12 mg. What I would say is that if a patient is more than 70 kg body weight, you can add 3 mg for every 15 kilo weight gain. That means if a patient is 85 kilos, then you give 12 plus 3, 15 mg once a day for 3 to 5 days, and then weekly or fortnightly depending on exposure.
So it seems to be
Thank you.
150 micrograms per kg body weight.
Yeah, so 0.2 na.
So every Indian has got 60 kg weight.
No sir, no
So-
sir. अभी यही कह रहे हैं ना कि हमारे को 11 किलो वजन लूज करने की जरूरत है. We are not 60 kg. We are getting more obese. So for a 60 kg individual, for a 60 to 70 kg individual, 12 mg tablet of ivermectin given for 3 to 5 days initially, and then weekly or fortnightly depending on exposure.
Once a week.
So doctors should probably take
For
it
how
once a
long?
week, as long as you want to, sir. Totally harmless.
Okay. Thank you. Thank you.
I'm going to do one full thing on ivermectin. Its chemistry, its origin, its effects. I'm going to do one full thing on ivermectin. I really like this drug.
Dr. Nidhi,
Good one.
Mm-hmm.
fluoxamine, what is the
Ji,
role
sir.
in preventing the morbidity?
Fluoxamine is an antidepressant
Yes.
which works on the serotonergic uptake. So it has a similar role as Ciplactin. So it's anti-serotonergic, and it does not allow serotonin to bind to immune cells and prevents but it also causes increase in circulating serotonin. Ciplactin blocks the release of serotonin. So in the short term, we can use Ciplactin in the dose 4 mg up to 3 times a day. And then because fluoxamine का जो effect है वो 2 हफ्ते लेता है, 10 days to 14 days for onset. So you can start with ciplactin, get the acute crisis under control, and then move on to fluoxamine in the longer term. Why they thought of fluoxamine was because patients in the mental health institutional setting were not getting severe COVID. So they believed that serotonin has some role in that.
Dr. Nidhi, Dr. Manisha here.
Ji, ma'am.
Now that everything, all the sero survey, especially in Delhi, are saying more than 90%, 99 in South Delhi are positive. So what is the future for us and what are the instructions? People have just given up the mask, having gatherings and whatnot. So now in our colony also we got 2 imported cases, one from Mizoram, one from Odisha, both vaccinated. So what is the thought process on that?
Ma'am,
For Delhi.
my thought process globally is that जब तक हमारे को कम से कम 1 महीना, preferably 2 महीना, rolling averages and daily caseloads का balance नहीं दिखता towards decline. So Maharashtra follows the policy of 2 week. कि अगर हम देख रहे हैं कि daily caseload weekly average से कम है for 2 weeks, we can say that we are out. I would say for 2 months, which means that we have to watch till December. And we cannot give up on testing. We cannot give up on tracing. We cannot give up on COVID appropriate behaviors. If at all people want to have gatherings, they have to be immune bubble gatherings where you do not then mix with. So supposing I am a doctor, I'm going to meet 100 patients a day. I cannot be part of any immune bubble.
Okay.
So it's matlab hum log, we individual doctors can drive the COVID appropriate behaviors if the population is letting go.
Yeah.
मेरी रीडिंग है कि हमारे को probably March 2022 में significantly पता लगेगा कि क्या हुआ. अगर कोई और emergent strain नहीं आया तो हम March 2022 में कहेंगे कि अब masks can come off, not before that.
Because
maybe like at least some
there
time
are
after Diwali has to pass for us to be able to say that, because
whereas in Delhi, I mean, as of now, right now we are protected, it seems. But around India, there are 14,000 as on yesterday or day before, and 500 deaths plus.
और उसमें से 80% are in Kerala.
And 1.5 lakh active cases. Much on.
Yes. So Maharashtra, Kerala, and Northeast seem to be driving it right now.
Right.
And these are the places where so the polarization and the politics around it is, I think, very bad. I think we need to talk science rather than politics, and work on our population rather than administration.
Also, the 2 cases I'm speaking about, Mizoram and Odisha, both were vaccinated, fully vaccinated.
it's
So
not a sterilizing it's not a sterilizing immunity that we get from vaccination. It's not. Infections तो होंगे, especially जिन लोगों को नहीं हुए हैं उनको तो होगा ही.
But they had proper symptomatic and 102 fever types. I mean, it was another.
Even I have been seeing some cases. We are getting 102 fever तक जा रहा है, 40% तक lung involvement हो रहा है, but steroid देने की जरूरत भी नहीं पड़ रही है. After the 7th or 8th day recovery हो रही है. That's, I mean, for the fully vaccinated people.
Okay. Yeah,
so
that
I have. Yeah, so I didn't. I've seen a couple of cases in the recent past. I've seen 102 तक fever भी गया था, and this was in the 4th day, and I was just with treating with Meftal and colchicine, and by 8th day almost they were better. So I was giving, of course, thoda sa dry cough tha, so we were monitoring the cough and the CRP very regularly, and the CRP didn't go above 18, if I'm not mistaken. Yeah, it didn't go above 18. So recovered quite well, fully vaccinated tha, like entire family. So I'm pretty sure it, जैसे अभी डॉक्टर नवी बता रहे थे कि डेल्टा का विद इन अ कपल ऑफ डेज एंटायर फैमिली इज इन्फेक्टेड, एंड अल्फा में बहुत काफी ज्यादा टाइम लगता है. So similarly, like within a couple of days, the entire family of 5 or 7 people were infected, but everyone came out okay.
Right, right. There is another request or offer from me. Dr. Kiran Vinayak is here, and I think he is in your group. I'm not. Daily, I'm conducting a yoga session for all doctors and families and their friends.
All right.
So every day except Sunday. So whoever is in AMV will know what I'm speaking.
Okay.
So we have a very good response. 36 doctors said yes. Almost 50 said yes, but end up 20 odd people every day. So if you all wish to join, Dr. Kiran Vinayak, is she around? I request her to share the link with you all on the group.
Okay.
Has she left?
No, she's here.
Dr. Manisha, are you there on the?
I'm here. I'm here.
Dr. Kiran.
हाँ, I'm here. मैंने डाला था आपका इस ग्रुप में, मैंने आपका डाल दिया था.
अच्छा अच्छा, ठीक है. आप if you would like all the doctors request, please join. Anti-inflammatory.
Definitely you should all join. बहुत अच्छे से और बहुत पेशेंटली सिखा रही हैं.
हाँ, no, निधि again last time ना NO रिलीज करने के लिए.
हाँ जी, हाँ जी.
It is called विरेचन क्रिया.
Okay.
वो हम करते हैं. पूछो डॉक्टर विनायक से. हालांकि अभी ये थोड़ी सी लैक्स हो गए हैं, but she's a great enthusiast.
लैक्स हो गई हूँ because I'm suffering from acute spondylitis after I came back from Goa. बहुत travel precipitates my attack. That is why I'm absent.
Very sad, but then धीरे धीरे आ जाओगे.
But I will join. I will join within 1 or 2 days.
So please share the link so that all can benefit.
Okay.
So there is a question by Dr. Samita Sharma saying, does Ciplactin cause addiction, and hence is it a banned drug?
No, Ciplactin is the effect of Ciplactin is also to enhance appetite. So it was misused in the previous avatar for appetite enhancement in skinny individuals. That is the reason why it was in controversy, not because it is addictive.
Weight gain के लिए हम लोग, मुझे याद नहीं है उस tablet का नाम.
Ciplactin.
नहीं, Ciplactin
or Ciplactin.
Cyproheptadine.
हाँ, वो तो ट्रेड ये जेनेरिक है.
जेनेरिक नेम है. हाँ,
एक पुराना ट्रेड नेम होता था.
लॉन्गिफिन के नाम से आता था.
किस नाम से?
लॉन्गिफिन.
Okay.
Yeah. And Practin also,
yes. So it's not addictive. It has been misused in the past.
And amphetamine also. Amphetamine for appetite. Amphetamine.
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 Amphetamine, right. It is not a antidepressant, because after all it does have a.
But it is still in on controversy. Amphetamine. It came in Times of India recently, 1 week back. Amphetamine, cyproheptadine.
The chemistry of cyproheptadine is antiserotonergic as well as antihistaminic. So it works in mitigating the immune platelet effects of COVID. I don't know what is the controversy. अगर आप share करोगे group पर तो it will be nice. But it definitely helps in most parameters for COVID.
Some of the Hollywood actress picture was given. with apetamin.
मैम वो तो सब कुछ ही करते रहते हैं ना, वो तो क्या
हाँ, इसीलिए वो बैंड उसमें आ रहा था सेक्शन में.
उसका तो ये हाल है कि जो इतना फेमस सिंगर, he used to get doctors to come and inject him all different cocktails and then he died finally.
माइकल जैक्सन.
Michael Jackson.
माइकल जैक्सन ही था.
हाँ.
माइकल जैक्सन was.
एक सेशन ओबेसिटी और एक डेंगू को भी दे दें.
जी जी सर जी.
We are seeing lot of dengue patients these days.
ये बताओ, मलेरिया के तो बताया गया 15-20 mosquito bites are a must. I mean generally. ये डेंगू में कितने bites होने चाहिए?
मुझे नहीं I don't know. पर ये है कि अगर घर में एक भी मच्छर होगा ना तो वो मुझे जरूर चिपटेगा. So I know.
मुझे भी.
So I know wherever I sit, I keep a bug repellent and I spray myself rather than spraying my surrounding.
I've got one point. If you
Ji,
reduce
sir.
the lactic acid from the sweat,
Same with me. Same with me. I always carry my coil wherever I go. Mosquito
lactic
मुझे
acid
जरूर
in
काटता
sweat
है.
attract the mosquitoes.
अच्छा.
Lactic acid excretion to be
हाँ.
reduced from the sweat, then we can be better from mosquitoes.
And how do we do that, sir?
We have to
Lactic
see
acid
the
अगर muscle
metabolism.
अगर आप लैक्टिक थ्रेशोल्ड पर एक्सरसाइज कर रहे हो तो लैक्टिक एसिड तो आएगी, और लैक्टिक थ्रेशोल्ड पर एक्सरसाइज नहीं कर रहे हो तो आपकी ओबेसिटी नहीं जाएगी. तो ये तो
नहीं, क्या करता है लैक्टिक एसिड?
ये कह रहे हैं सर कि अगर आप लैक्टिक